For term newborn infants who do not require immediate resuscitation, deferred cord clamping for at least 60 seconds can be beneficial when compared with immediate cord clamping. For non-vigorous term newborn infants and late preterm infants 35 weeks or more gestational age, intact cord milking may be reasonable when compared with immediate cord clamping. For newborn infants born at less than 37 weeks of gestation who do not require immediate resuscitation, deferred cord clamping for at least 60 seconds is recommended when compared with immediate cord clamping. For newborn infants, initial peak inflation pressures of 20 to 30 centimeters of water are reasonable, with adjustment of peak inflation pressures to provide effective ventilation. It is reasonable to provide ventilation at a rate of 30 to 60 per minute in newborn infants. Video laryngoscopy can be useful for newborn infants who require endotracheal intubation. It is reasonable to use a laryngeal mask as an alternative to endotracheal intubation for newborn infants at 34 weeks or more gestational age for whom ventilation via face mask is unsuccessful. It may be reasonable to use a laryngeal mask as the primary interface to administer ventilation instead of a face mask for newborn infants born at 34 weeks or more gestational age. A pulse oximeter should be placed as soon as possible for newborn infants receiving respiratory support or supplemental oxygen. In preterm newborn infants born at less than 32 weeks gestational age receiving respiratory support at birth, it may be reasonable to begin with 30% to 100% oxygen. It may be reasonable to compress over the lower third of the sternum, taking care to be above the xiphoid process when providing chest compressions to newborn infants. It may be reasonable to change compresses every 2 to 5 minutes when providing chest compressions to newborn infants and to switch compresses while heart rate is being assessed.